In obstetrics, it's a lot more straightforward. I used to have a professor that used to say, you don't need an ABGA score of 10 to do obstetrics and gynecology. It's very straightforward. So we'll start, and I'll start with a very short story, a true story. And it's about Mrs. MF, a 30-year-old traveler, 3 per 1+1, presented in labor at 40 weeks, and she labored at home, attended by a local midwife. She spent 10 hours in labor. She had ruptured membranes 24 hours before then. She had several examinations at home, delivered at home, live baby, had a retained placenta, had to be referred to a primary health care center to have that managed. Now, please remember this lady because we'll refer to her even at the end of this presentation. So these are the objectives of the presentation. First of all, we'll define what puerperal sepsis is. Quite often you see that puerperal sepsis is confused with another definition or is subsumed in something else that we'll look at as we go on. We'll talk about the predisposing factors, and as we talk about that, please cast your mind back to this patient I just presented. We'll list common causative organisms for puerperal sepsis. We'll discuss the signs and symptoms, and then we'll discuss the treatment and prevention of puerperal sepsis. So let's first of all define what the puerpera is. Puerpera, as with most words that you see in medicine, has a Latin origin. Puer, that's P-U-E-R, stands for child, or boy child actually. And then the other bit there, pera, or peros, means to bring forth in Latin. So it was, as with many English words, as it's used in English, it's stolen from Latin. And if you consider the word literally, it means to bring forth a child. That's what puerium means. And in obstetrics, it refers to the first 6 weeks after childbirth. It's interesting we use 6 weeks because the Americans stretch it to 12 weeks. But being that we're British trained, we use the British system, we stick with 6 weeks. It is a period of a lot of readjustments. If you remember, there are some physiological changes that take place in pregnancy. The increased blood volume, increased pulse rate, changes in the respiratory system, and the hematological system, and all the rest of that. In the puerperium, in these 6 weeks, everything that happened in pregnancy that God made there to prepare her for having that baby begins to revert back to the pre-pregnancy period. And some of these things are very dramatic. After delivery, the uterus will weigh 1 kilogram, as much as that, in a term pregnancy. By the time the puerperium is over, that uterus will go back to about 100 grams. Isn't that amazing? And it will be about the size of a fist by the time the puerperium is completely done, assuming everything is normal, that is. And in that period, there's a lot of readjustments, not just physically as well and physiologically, but also mentally. And that brings about other complications that you have in mental health. Well, that's a story for another day. Puerperal sepsis was the leading cause of maternal mortality up until the 1937. And why this was so, it used to be called childbirth fever, milk fever, and the rest of them, and it killed a lot of women. And the reason was just one thing: lack of hygiene. There was this gentleman, a Hungarian obstetrician called Semmelweis. Many of us may have heard about him. Semmelweis is basically the father of asepsis, not just in obstetrics, but generally surgical procedures. And then, if you remember, just think back that the germ had not even been discovered then. So people didn't even know that there was a microscopic agent that was responsible for disease. And what did he say? He discovered that the wards were overcrowded, pregnant women in labor were attended to by midwives and obstetricians, and almost half of them would die after delivery, uncomplicated deliveries. So one of his colleagues, whose name was Yosef or Yaakov, died after attending to a woman, after performing an autopsy on a woman that had childbirth fever, as it was known, or milk fever. And he had cut himself with a scalpel that he used in her autopsy. And when he did his own autopsy on his friend, he found evidence of infection. So he thought to himself, could there be a link? And his intervention was simple. Midwives, doctors, wash your hand with chlorinated water. And there was a very huge drop in puerperal sepsis, and women survived. But as with everything new, the doctors were offended that this man would say they should wash, he would then see that doctors are dirty and they should wash their hands before attending to women. How could he say this thing? And even until he died, he was not given the credit for this until after his death. Interesting side story, but this is the reality. It also coincided with the discovery of sulfonamides, and this reduced, in 1935, that is, reduced the mortalities from sepsis. But it is still a leading cause of maternal mortality in developing countries, even now. It is estimated that globally, about 5 million women have puerperal sepsis. Most of them will be in the developing world. And the maternal mortality that is attributable to puerperal sepsis in the developing world is as much as 33%, which means if 100 women have deliveries, 33 of them will die because of puerperal sepsis. Combined with obstetric hemorrhage and hypertensive disorders in pregnancy, it forms a lethal triad of why women die from pregnancy in Nigeria. And those that do not die have severe morbidities and chronic long-term problems that we'll consider. So the incidence, again, in Nigeria, as with most things that require statistics, it is underreported because the diagnostic criteria tends to differ, and so many women may not even deliver in hospitals where these records are kept. But from what we have, 16.7% for Jos. That was the incidence of this morbidity in women that delivered in Jos. 0.9% in Sokoto, and then 9.34% in Port Harcourt. The value for Sokoto actually is the same one that they had in a study in Ibadan in 2022 that was reported. So you see, it is quite a big problem. How do we define it? The World Health Organization defines it as infection of the genital tract occurring anytime between the rupture of membranes or labor and 42 days postpartum, in which there are 2 or more of the following. So rupture of membranes occurring any genital tract infection occurring after the rupture of membranes, labor of 42 days postpartum, which is 6 weeks, that is associated with 2 or more of the following symptoms. Pelvic pain, then a temperature of greater than or equal to 38.5 degrees centigrade on any occasion. On any occasion. Please take note of this because you see in the next slide a definition of puerperal pyrexia, which I told you many people tend to confuse the two terms. They are not synonymous. Puerperal pyrexia is not puerperal sepsis and is not synonymous with puerperal sepsis. Please remember that. So, pelvic pain, temperature greater than or equal to 38.5 degrees centigrade on any occasion during this period, abnormal vaginal discharge, and delayed uterine evolution. If you have any of these two things, you have evidence of infection of the genital tract anytime between the rupture of membranes, labor, or 42 days postpartum with any of these things: pelvic pain, pyrexia greater than or equal to 38.5 degrees centigrade, abnormal vaginal discharge, and then delayed uterine evolution. The uterus usually involutes at a certain rate. That is at least 2 centimeters per day. If it does involutes less than 2 centimeters in the first 8 days, then there's something wrong. If you remember, after delivery, if you palpate the uterus, it will just be sometimes above the umbilicus. Yes? But within the first 2 weeks or so, it should start dropping. In fact, you should not be able to palpate it above the symphysis pubis after 2 weeks, unless something is wrong. We'll look at the normal process later on. So this is a definition of puerperal pyrexia. Puerperal pyrexia, see the difference. This is a rise in temperature of 38 degrees centigrade measured on 2 separate occasions, yes? After the first 24 hours, yes, 4 to 6 hours apart usually. After the first 24 hours and within the first 10 days of delivery. You see the difference between this? Here you have a documented genital infection. You have evidence of it. Here what you simply have is pyrexia after the first 24 hours, measured 2 times 4 to 6 hours apart within the first 10 days of delivery. What that means is that this pyrexia could be from anything at all, not a genital tract infection. It could be from malaria, it could be from thrombophlebitis, it could be from mastitis, it could be from a deep venous thrombosis, it could be from a chest infection, it could be from anything at all. That is puerperal pyrexia. Puerperal sepsis, however, the focus or the start of the infection is from the genital tract. Are we together? So please, let's not mix the two. So I'm just re-emphasizing that genital pathologies may cause puerperal pyrexia. And we should not confuse puerperal sepsis with puerperal pyrexia. So let us talk briefly about what you expect in the normal puerperium, so we'll understand when things are abnormal. In uterine evolution, there's a process of autolysis. The uterine muscle mass, by a process of autolysis of the cytoplasms of the muscles there, starts to evolute. And all the products that are thereafter released are excreted by the kidneys of the woman. And if she is breastfeeding, the release of oxytocin will speed up the process, particularly if she's exclusively breastfeeding. If she's not, the process takes longer of uterine evolution. Also, if she has had uterine surgery, perhaps she had a cesarean section, the process takes longer. If she had a multiple pregnancy, the process takes longer. If there are still products of conception in that uterus will not evolve as fast. If there are blood products there, it will not evolve as fast. If there's an infective process there on inflammation, it will not evolve as fast. Which is why cesarean section usually will be associated with sub-evolution, because the surgery itself, you have breached the uterine cavity, you have applied the foreign body, you have sutures, there will be some endometritis there, typically, and the process may slow down. But if everything goes on fine, within 2 weeks, like I said earlier, that uterus should only be palpable by manual pelvic examination. You will not feel it above the pubic symphysis. But, a caveat here, if there's a delay in evolution without any other signs or symptoms, then it's not of clinical significance. What do I mean? Yes, you think the process of evolution is slower, but she doesn't have pyrexia, there's no pelvic pain, there's nothing like that going on, there's no They'll put many things there, put their things to eat, they'll just use it as the time to be gisting. Many of these people come with a lot of their stuff. And they can cause a lot of problems, particularly even for cesarean deliveries. They can really compromise the wound, but even for vaginal deliveries. Then proper postpartum care. Elsewhere, women are followed up by someone who visits them at home after delivery. That's what they do in the UK. Someone visits them, makes sure they are fine in that same period. Can we do that here? I wonder. So in conclusion, puerperal sepsis, we don't have enough people even in the hospital. How much of those going at home? It's a preventable condition, preventable cause of maternal morbidity and mortality, but with good antenatal care and aseptic delivery practices, you can reduce the incidence and the mortality that is attributed to it. Thank you for listening. That's some of my references. I think we have time for questions, isn't it?
Yes, we always have time for questions. Thank you very much, sir. Please let's clap again. So we'll give opportunity for questions. If you have questions, just let's raise our hands so that we'll take all of them together and then we'll answer. We have one here. Please, those of us that are online, if you have questions, just put it on the message box. 2, 1, 2, any other? Don't start raising up your hand when you start asking, like, Anand. Okay, so let's hear.
Thank you very much, sir, for the beautiful lecture. My question is your take on the use of antibiotics in normal delivery without any laceration being sustained, because some centers don't give antibiotics. And then, sir, the definition of puerperal pyrexia, is it a misnomer? Because you said within the first 10 days, and then we're told that puerperal period is 42 days.
Thank you.
Thank you so much, sir, for your presentation. So I just want to get your comments regarding prevention, especially in an environment where we talked about the place of unskilled bed attendants at home. Apart from puerperal sepsis, there are a lot of complications that, because of them attending to these women at home, they present to the hospital. I don't know, in our own setting, what are your suggestions on how to reduce this complication of puerperal sepsis and generally maternal mortalities that come from those kind of settings? Thank you.
So that can come because they are attended to by unskilled attendants,
yes.
TBs.
Yes, which is the case in the environment most times.
So please help us check online for that. Okay. So there's no question online.
Alright. So I'll address the first question. So it is not recommended for women who have uncomplicated deliveries to get, as vaginal deliveries, to have prophylaxis. It's not, there are recommendations that came from worldwide studies actually by the WHO, and they do not recommend prophylactic antibiotics to be given to women that have a normal vaginal delivery, no lacerations, no episiotomy, nothing. It is an abuse of antibiotics. All you can teach them about is hygiene, proper disposal of the sanitary pads, and that's it. Yes, or you do not give prophylactic. It's once you do that, in fact, you're increasing the resistant strains, so we don't give them as a routine. So that's all. I think I've answered that. Then the second question we answered. Yes, there are many things in obstetrics that sound like misnomers. This is one of them. Yes, we don't say puerperal pyrexia extends to 6 weeks. We exclude the first 24 hours because of the response to stress and inflammation. You may have some pyrexia there. So if we exclude the first 24 hours after delivery, remember I told you there's autolysis and all of that can stimulate an inflammatory response. You may have pyrexia. Excluding that, from the second day to the 10th day, if you have any temperature greater than 38 degrees, 38.5 degrees centigrade, measured 2 occasions, that is what qualifies as pyrexia. It doesn't extend to the 6 weeks. Don't ask me why, but that's how it is. Yes, and that is why you see, like I said earlier, the Americans take their own to 12 weeks. Anything that occurs within that 12 weeks, for them, is not, they stretch that diagnosis even for the puerperal sepsis to 12 weeks. But pyrexia, even for the Americans, is limited to the 10 days. Yes. All right, so the final question, prevention. Yes, you're talking to an obstetrician. I'll never tell you that they have a place. I'm sorry. Because we have seen a lot of damage that TBAs have done. The damage they cause is more than the so-called good they do. And people only use TBAs for two reasons. I won't say only. It'd be interesting to know that sometimes the use of TBAs is not about money. Some of them charge more than we charge in June. Yes, seriously. And they charge in kind. Bring 5 tubers of yam. How much is 1 yam now? Yeah. Or give me salt and all that. But sometimes it's the interaction with the healthcare worker. You go to the hospital, the midwife is shouting at them, "Madam, open your legs. Open your legs." Was I there when you were doing this thing? Shouting at them. No patients complain about that. Yes, I can tell you, I know a lawyer who I met privately. He said she will never go to Jude again. Because when she delivered, she had an episiotomy that was repaired with very little analgesia. And it was by a woman. I've been looking for who that doctor is for a long time. It was by a female like her. And it was such a bad experience for her, she said she would never go. So some of these TBAs, their interactions with the patients are a lot better than us. Some of them also allow them to deliver in positions they want. Yes, a Fulani woman will come and she'll say she wants to squat. And you say, no, you must lie on your back. It may interest you to know that squatting is a recognized position for delivery. There are actually beds that even allow it. So there's nothing wrong with it. But because you are used to this, you say, no, lie down. They don't want that. In fact, there are studies that are done, even here in Truth, that show that that's one of the reasons women will not deliver in the hospital. So what am I saying? Increase the number of skilled birth attendants. I don't support the fact that people say train TBs. They are so set in their ways, I'm sorry. Some people have had some success there, but truly if you see one patient that comes with damage from that, you hesitate. So there are places, train them enough to recognize when to refer patients on time. That has been shown to be effective. I think maybe that is what I'll concede. Yes, I think I'm done with all the questions. Thank you.